So my name is Péter and I am working here in the department, and I am one of the examiners as well. So the only topic which I have as a lecture in the first semester is the knee joint and the plantar arches of the foot. So the first part will cover the most important informations about the knee joint. Basically here we won't have time to go through every little detail. I want to give you a guideline and some insight to the most important things about the knee joint. So first of all, this is the largest and also the most complex joint system in the human body. The knee joint is not standing alone. I explained it to you. So obviously it's a standalone joint, but from a functional point of view, it does not work alone. Since it is one of the joints of the lower limb between the leg and the thigh, so its mobility and its supportive function is always connected to the joints above and below. So the knee joint on its own is working together either with the hip joint or with the ankle joint or joints. Okay, so the knee joint will almost always work together with the joint above it, that's the hip, or the joint below it, that's the ankle. So the knee joint has very high mobility and the quite large range of motion. Since it's a very mobile joint, its stability can be an issue. Put together this with that it has a very high load and a lot of stress, especially if you are jumping, land on one foot only, then the complete body weight plus the momentum of the movement will be put onto the knee joint. So because of this, the knee joint has lots of different diseases, both injuries, so traumatic disorders, or degenerative disorders, which build up with age, and also very dependent on the stress which the knee joint has to suffer. So with this short introduction, let's move on to how the knee joint is composed. So you have the following bones contributing to the formation of the knee joint. Obviously, you have the femoral bone, so the bone of the thigh. Then you have the two bones of the leg, the tibia and the fibula. Here, I want to highlight that the fibula does not take a part in the formation of the joint. It is only connected to the knee joint by ligaments. So it's not contributing any articular surface to the knee joint itself. Instead, you have a tibiofibular joint here, which is basically supporting the lateral tibial condyle. Okay? And then we also have the patella. The patella is a very important part, actually, of the knee joint. It is basically the largest sesamoid bone of the human body. Sesamoid bones are those ones which are embedded into tendons of muscles to help with the force conduction there. So the patella is basically connected to the largest muscle of the thigh there, the largest extensor muscle of the knee, which is the quadriceps femoris muscle. So that is the patella. Okay, so with all these bones, basically you will have the following parts of the knee joint. So first of all, you have the connection between the femoral bone and the patella, which you call the patellofemoral joint. And then you have the connection between the tibia and the femoral bone, which is the tibiofemoral joint. This latter, the tibiofemoral joint, will be divided into a medial side and a lateral side. And this joint works as basically a hinge joint combined with a small pivot part. So it's a combined hinge pivot joint altogether. And you also have this already mentioned tibiofibular joint, which has an accessory function to support the lateral part of the tibiofemoral connection. Let's have a look at the female part, which is the tibial proximal surface, which you also call the tibial plateau. So there you have the medial and lateral tibial condyles, which have flat surfaces, basically. If you look at the distal end piece of the femoral bone, that is having a round shape. So this means that the two articular surfaces do not match together perfectly. So you call it an incongruence. So this has to be addressed somehow. That's why you have the menisci, these cartilage ring-shaped structures, put onto the female part, so onto the tibial condyles. These menisci are mobile structures. So as the knee joint is producing movements, these menisci also change their position, and also they are able to change their perfect shape to shape to perfectly match the curvature of the femoral condyles in every position of the knee joint. They will be attached to the middle part of the tibia, which is separating the medial and lateral half, or medial and lateral condyles of the tibia. So there you do have a so-called intercondylar eminence, and that's where you have the attachment of the menisci. The lateral meniscus is attached to this intercondylar eminence here on both of its ends. However, the medial meniscus only has a direct connection there to the bone in its posterior end. The anterior end will have a transverse ligament of the knee, or transverse genus ligament, which then connects it to the anterior end piece of the lateral meniscus. So this means that the medial meniscus has to be supported by something else in order to be more stable. So here you can see that the medial collateral ligament is also connected to the medial meniscus. Moreover, the medial part of the joint capsule will also be attached to the meniscus. This altogether means that even though the medial meniscus is still mobile, it has much less mobility than the lateral meniscus. This will also explain why the medial meniscus is more prone to injury than the lateral meniscus. Here you also see in the middle, in front and to the back of this intercondylar eminence where the menisci are attached to, you see the intrinsic ligaments of the knee joint, the anterior and the posterior cruciate ligaments. On the other side here you have the lateral collateral ligament, which is then connected to the head of the fibula. So this is connection, an indirect connection between the joint and the fibula. Okay, so this is what the female part looks like with its accessory parts. Then let's have a look, and we approach the knee joint layer by layer. So obviously the most superficial layer, the skin, is already removed here, and the pictures only show you the muscles, tendons and ligaments of the surrounding area. So this is the front view, anterior view. Here you have the location of the patella, which is basically covered by the tendon of the middle part of the quadriceps, which you call the rectus femoris muscle. So that goes above the patella and then continues here in the patellar ligament. The deeper parts of the quadriceps muscle are called the vastus muscles, and there you have a lateral vastus, a medial vastus, and an intermediate vastus. These will be connected to the base of the patella, as an insertion, but then the force of the muscle as it contracts will be conducted onto the tibia also through the patellar ligament. The most medial and most lateral parts of the vastus medialis and vastus lateralis muscles, respectively, will not have any more space on the base of the patella, so they have to be inserting somewhere else. And that's where you have the medial and lateral patellar retinaculum. So the patellar retinaculum is basically framing the patella in the middle. So here you have this sort of framework made from connective tissue on the medial and lateral side. The patellar retinacula can be divided into longitudinal and transverse fibers, but you basically don't need that much detail. So the important thing is that next to the patella you have these patellar retinacula. These can also be injured, and in this case the patella can be dislocated either to the medial or to the lateral side, which is, first of all, it is looking horrific. Secondly, it's quite of a painful injury. Okay. On the back side, you have a different set of muscles covering the knee joint from the back. First of all, here, traveling through, you have muscle pieces and also tendons of the flexors of the knee, which are located on the back side of the thigh, and you also call them as hamstring muscles. But you also have some flexors of the leg, which are right there. So here and here you see muscle origin sites for muscles of the leg, flexor muscles of the leg. And you also have another muscle which is exclusive to the knee joint, that's called the popliteus muscle. The importance of the popliteus muscle is that here, so on the back side, laterally and inferiorly, you are missing a layer of the capsule. So basically you have there a sort of an opening on the fibrous layer of the capsule, but please note that this is only found on the fibrous layer of the capsule, so there is no leaking of synovial fluid or something like that, because the synovial layer of the capsule is continuous, only the fibrous layer is missing. And this kind of opening, this hole on the fibrous layer will be basically patched. So the fibrous part of the capsule is basically replaced by the popliteus muscle. This is an important thing to know. Okay. One more thing. Here you have the tendon of one of the hamstring muscles, so flexors of the knee, which you call the semimembranosus muscle. The semimembranosus tendon is inserting to this area, and then there is an oblique popliteal ligament going this way, which then supports the posterior part of the capsule. This will prevent impingement of the posterior part of the capsule when you make a flexion of the knee. Without this ligament connecting to the tendon, the capsule would just freely move in between the femoral bone and the tibial bone, and there it would be impinged and injured. So this should not happen, and that's the function of this oblique popliteal ligament. All right, so this was the these were the most important things of the first layer.
Professor, you're muted.
Oh, somebody muted me. It wasn't me. Which was the last part which you could hear?
About the pinching of the capsule behind.
Okay. So let's move on to the next layer by removing the muscles. So then you can expose the capsule, and here in this picture you see how the capsule is connecting to both the femoral and the tibial surfaces. And in between the two surfaces here you have the meniscus. So the capsule will also have an attachment on the femoral bone, and then the meniscus is basically interrupting it, and then it continues from the inferior margin of the meniscus to the tibial articular surfaces. So this is basically this bluish, greenish, bluish color is showing you how the synovial layer of the capsule is connected to the surfaces and the menisci. The fibrous layer, however, does not perfectly follow the synovial layer, especially here where you have the meniscus and the tibial surface. There you can see that there is a disconnection between the fibrous layer of the capsule and the synovial layer of the capsule. The fibrous layer of the capsule will be connected to the patellar ligament in the middle and to the patellar retinaculum, to the medial and lateral sides. In between the fibrous and the synovial layer, you will have a fat pad, which is called the infrapatellar fat pad, and that will produce these folds of the synovial layer. So that's what you can see here. In the middle, you have the infrapatellar synovial fold, which then will connect to the cruciate ligaments and surround them. This will make the cruciate ligaments located inside the capsule, so in an intracapsular location, but outside of the actual synovial cavity, so extrasynovial, intracapsular but extrasynovial. On the medial and lateral side, you will have two more folds, which are the so-called alar folds. So ala means wing in Latin, so these look like small wings. Okay, so that's what you have because of this infrapatellar fat pad. Okay, and then you have the lateral collateral ligament, and the medial collateral ligament should be there. The medial collateral ligament is much more flat and wider than the lateral one, which has more round shape. And another very important feature that the lateral collateral ligament is separated from the capsule. Even though there are lots of ligaments of joints which are basically connected or embedded into the capsule, thus strengthening it, but this is not the case for the lateral collateral ligament of the knee joint, so that's a separate ligament. Other ligaments like patellar ligament, patellar retinaculum, and the medial collateral ligament, these are in close relation to the capsule, so they are basically embedded into the fibrous layer of the capsule and strengthening the capsule. If we remove these parts and move further into the knee joint and clear basically every other part, then we see the joint surfaces clearly, so the femoral surfaces, the patellar, and the medial and lateral condyles of the femoral bone. Then you can see the collateral ligaments, medial and lateral collateral ligaments. Here, please note that there is no distance, no gap in between the medial meniscus and the medial collateral ligament. From the front and from the back it is clearly visible, but you still see here a gap, so there is a small space, there is a distance in between the lateral meniscus and the lateral collateral ligament. So there is no direct connection here to the capsule or to the lateral meniscus from the lateral collateral ligament. That's a separate ligament. And then here you see the intrinsic ligaments as well, the anterior cruciate ligament and the posterior cruciate ligament. Note please that there are some atlases, these pictures have been taken from the Themes atlas, where the term cruciform is used instead of cruciate. I would suggest you don't use that. So call them cruciate ligaments. That's the proper anatomical term, okay? Cruciform would mean something different. I'm not going to explain that. Just take it like as it is. So you should call it cruciate ligaments or cruciate ligament, okay? From the back, you can see the back side of the posterior cruciate ligament, and the anterior cruciate ligament also can be seen here, which will be partly covered by the posterior meniscofemoral ligament, which is connecting the lateral meniscus to the femoral bone here of the in basically the inner surface of the medial femoral condyle. Okay, so that's how the knee joint, the deepest layer of the knee joint, looks like. We take the lateral and the medial point of view of this deepest layer as well. So here you have quadriceps tendon, patella, connected to the patellar surface of the femur. Then you have the patellar ligament, which will then connect to the tibial tuberosity down here. Here you have this huge space then in between the femoral condyle surface, the lateral meniscus, and the tibial plateau or tibial condyle surfaces. So this is where you have this disconnection between the fibrous layer of the capsule, basically the patellar ligament, and the synovial layer of the knee joint capsule. So this is where you have this fat pad and the folds of the synovial layer made by these fat pad parts. Okay. Then here you see the lateral collateral ligament, and that was the lateral aspect. Medial side, here you see the medial collateral ligament. Please compare the size of the collateral ligaments. So the medial one is much more wide, but also flat instead, round in shape and more narrow. Okay, and would like to remind you that there was no gap in between the medial meniscus here and the medial collateral ligament. So here you also have a connection between these two structures. So, or three structures, because capsule, medial meniscus, and medial collateral ligament, these are interconnected. Okay, further details in practical classes, and also I would highly advise you that you should come into the open dissection room sessions and have a good look at different knee joint preparations, because some of them are less dissected, so you have the outer layers on it as well, and some are more dissected, so the most inner parts can be seen there. So and check these, please, and because in 3D it's much more useful to have a look at it than in 2-dimensional atlas pictures. You cannot really understand how it looks like if you don't look at it and don't touch it, smell it. Okay, so movements. Since it is basically it's a hinge joint combined with some pivot elements. So the most important movements which can be produced are flexion and extension. The pivot elements are the posterior parts of the femoral condyles, which are much more round in shape than the distal part of the femoral condyle. So this means that internal and external active rotation of the knee joint can only be produced in flexed position. Okay? So it is, even though it is truly a hinge pivot, but it is not like the elbow joint, where in any position of the elbow joint, both movements, so both the rotational movements, the supination and pronation, can be produced, and flexion and extension, obviously. Here, internal and external rotation are only possible in the flexed position. Okay? There are several factors causing this. First of all, the shape of the femoral condyle. So in order to produce rotation, it has to be more round, and that only happens in the backside. So when you have a flex position and the backside of the femur is connecting to the tibia, that's where it can do the rotational movements only. The second factor which contributes to that, it is not that clearly obvious in the picture, but I would like to point it out for you, that you see this and this, how the lateral collateral ligament looks like. This, in the extended position, looks much more stretched than in flexed position, where it's loose. Right? You can clearly see the difference between the two pictures. So this is another factor which allows the rotation in the flex position and prohibits the rotation in the extended position. So the collateral ligaments also loosen up when you have the flex position. In these pictures, you can see how the meniscus, lateral meniscus and medial meniscus structures are moving when you produce extension or flexion. This has to do with the exact shape of the femoral condyles, because the femoral bone, if you take a look at it, the posterior parts are more apart from one another than the anterior parts of the femoral condyle. So they have a conversion to the front and diverge to the back. This means that in a flexed position, the menisci have to slide a little bit posteriorly and move a little bit apart from one another. So this is what you can see here. Whereas in extended position, they shift forward and move a little bit towards the midline of the joint. These sideways movements are not that clearly shown in the picture, but the anterior-posterior sliding is shown clearly. You see here that the medial meniscus is also has moved to the back a little bit. Here you don't see the bony margin, which you can see here, and here you can't see this bony margin, which you can see here, and it is obvious with the lateral meniscus. So you see that the lateral meniscus, because it's not connected directly to the capsule or to the medial collateral ligament, it's much more mobile. So the lateral meniscus is more mobile, so it can dodge any sort of mechanism which might lead to its injury. Whereas the medial meniscus is very likely to get impinged if you do the wrong movement, and then that's causing its injury quite often. There is one more movement, the so-called passive rotation of the knee joint. The passive rotation occurs in the beginning of the flexion and the end of the extension movement, and it's caused by this special shape of the medial condyle of the femoral bone. Here you see the longitudinal axis of the lateral condyle, which is straight. So starting here from the patellar surface, you go all the way there with a straight line. However, the medial condyle will have this angle in it. Okay, so it starts like this, and then it has this angle and continues like this. I mean the longitudinal axis of the anterior and the posterior parts. Okay, because of that angle, if you so this blue ellipsoid is representing you the tibial surface. So this is how the connection between the two surfaces looks like when you have a flexed position. As you start to extend the knee, this part will start moving forward like this. And then it reaches the angle. And then this part will start to rotate that way. So this passive rotation at the end of the extension is basically an external rotation. See, like this. So this is a passive external rotation. And the other way around, obviously, the passive rotation which occurs in the beginning of a flexion is a passive internal rotation of the leg and foot. Okay, so external rotation passively of the leg and internal rotation passively of the leg. Okay, happens when you end the extension or start the flexion. It is not much, about 5 degrees altogether, this passive rotation, but it still has an importance and a significance. Okay, these pictures explain to you how the different positions of the knee, these improper positions of the knee, affect the parts of the joint, putting too much stress on the medial or the lateral tibiofemoral connections. So normally so this is the actual longitudinal axis of the body here. Here you see the anatomical axis of the femur, and here you see the anatomical axis of the tibia and the leg. And here you see the axis of the rotation of both the hip joint, which starts from the center of the femoral head, and it goes to the middle of the knee joint. So these are the different lines. You don't really need to know all these different angles. You just have to know that the longitudinal axis of the femoral bone is not the same as the rotational axis, which is not the same as the actual longitudinal body axis. Okay? Should there be any sort of medial shift or lateral shift in the positioning of the femoral bone and tibia, that will cause an overload put on either the medial side or the lateral side of the knee joint. If you have a shift to the lateral side, that is producing the so-called genu varum or varus position of the knee, which will obviously stress too much, so put too much stress on the medial part of the joint, and this will cause this overloading, this overstressing will cause sooner or later degeneration of the medial part of the knee joint. The other way around, if you have a medial shift in the positioning of the knee, this will cause the valgus position or genu valgum position, which will overstress the lateral part and cause the degeneration of that. So the healthy positioning of the knee joint is especially important. And you have to keep it in mind if you do, for instance, hip replacement or any sort of operation on the lower leg, that the position and the correct angles of the knee joint have to be considered. All right. Then let's move on and summarize the ligaments. So ligaments of the knee joint will be divided into intrinsic and extrinsic group. The intrinsic ligaments are the two cruciate ligaments, abbreviated in the clinical terminology as ACL and PCL. The transverse ligament of the knee connecting the anterior parts of the two menisci, and also the posterior meniscofemoral ligament is an intrinsic ligament. This was posteriorly connecting the femur to the lateral meniscus. Then the extrinsic ligaments, which can be seen on the outside, the collateral ligaments, MCL, LCL are the clinical abbreviations, the patellar ligament, medial and lateral patellar retinaculum, and the oblique popliteal ligament. Remember, this was preventing the impingement of the posterior part. So the structures of all these listed, which are the closest related together, that's the ACL, the anterior cruciate ligament, the medial collateral ligament, and the medial meniscus. And usually they are also connected not just by their anatomy, but also injured together. Most importantly, that's causing the injury if you have a rotation, a torsion, a twisting of the femur, so of the thigh and the leg in opposite direction. When does it happen? Falling down the stairs, or getting kicked by another person from the side, and your foot is moving medially, whereas you fall laterally. This happens very often in soccer injuries, or if you are falling in the hill slopes or mountain slopes when you are skiing. Okay, so that's when the knee injuries happen very often. I have no idea if these links, I should have checked them before the lecture, but these are showing you some knee injuries, so you can check them. So this concludes the knee joint, which I wanted to talk about to you today. And let's move on to the second part of the lecture, which will cover the arches of the foot, bony arches of the foot. Again, we have no time to throughoutly explain it. I'm just giving you several important points and highlights in order to orient you a little bit better than just simply textbook. Okay, so the arches of the foot. Here we continue from this picture, which shows you the points of the support for the body. So here here you have the connection between the spine and the skull. Here you have the attachment points of the cervical, thoracic, lumbar spine. Here you have the base of the sacrum, the hip joint, the knee joint, and then we arrive at the ankle. So all these points should be in line, and in line with the line of gravity, in order to have a good body posture and good balance of the body. This is very often destroyed by muscular imbalances or stiffness of different joints and so on. And that's why you have to know this in anatomy, that this is an important thing, because lots of diseases can occur if this normal body posture is no longer present in a patient. So the bony arches of the foot are located here below the ankle joint. So these are carrying basically the complete body weight. And you have, in order to better support the body weight, a better balance of the body, a better shock absorption to protect the joints from injury or degeneration, you have these arches of the foot, which produce a so-called lever mechanism. Before we continue, we should really briefly go through what are the main parts of the foot. So you have the tarsus with the tarsal bones, then the metatarsus, and you also have the toes, the phalanges. These bone structures form two groups of arches. You have a longitudinal arch, which then be divided into a higher medial and a lower lateral group of arches. And you also have a transverse arch, which will be further divided into a proximal part, which is much higher, and that's located at the tarsal area. And in the middle part here, so the metatarsal bones, the heads of the metatarsal bones more precisely, will produce the distal part of the arch. Here you can see that this really looks like a transverse arch. These two arches combined produce the so-called plantar vault, which is protecting the soft tissues of the sole of the foot from being compressed. So the soft tissues will include muscles, nerves, arteries, veins. So they need to be protected from pressure. The arches of the foot, both the longitudinal and the transverse arches, will be supported by active and passive components. The passive components are all of the bones of the foot and the joints which connect them with their ligaments. The active components include muscles of the leg, both anterior, lateral, and posterior, so flexors, peroneus, and extensor muscles are involved in this, but the most important ones are the peroneals and the flexors, these long muscles, and also the plantar region, so the sole of the foot, has short muscles, which are also contributing to the support of the arches. Here you see several important supportive structures for the longitudinal arch. First of all, there you see the long plantar ligament and the plantar aponeurosis. Since these are ligaments, they are belonging to the passive components. And here you see two very important active components, the flexor digitorum longus and flexor hallucis longus muscles with their long tendons, which have a crossing here. You also have the plantar calcaneonavicular ligament, which is a very important, a key structure basically in maintaining the medial part or medial group of the longitudinal arches, as it is supporting the head of the talus, but it is not only included in this in the formation of the longitudinal arch, but is also a very important part of the joint here, which is called the talocalcaneonavicular joint. The transverse arch. In the transverse arch, you have the following important structures. Here you have, again, an active component, which is a muscle of the leg, the tibialis posterior and its tendon. Then you have the fibularis longus tendon, which is again a muscle, a long muscle of the leg. And then here you have the most important short muscle for the support of the distal transverse arch. That's the adductor hallucis muscle with its transverse and oblique head. Another important thing is that the fibularis longus muscle is not alone. There is a loop of tendons produced by two muscles, the fibularis longus and the tibialis anterior. Tibialis anterior belongs to the extensor group, whereas fibularis longus belongs to the peroneal or fibularis group. They both have their attachment or insertion here at the medial cuneiform bone and the base of the first metatarsal. So here on the medial side and on the back of the foot, that's where you have the tibialis anterior insertion, and here the plantar side, and laterally here you have on the same two bones the insertion of the fibularis longus. These will have obviously antagonistic function to one another. So one is doing the pronation movement and the other one, the fibularis longus, is doing the pronation movement and the tibialis anterior is doing the supination movement of the foot. But as they work against one another, basically in the movements, they are also helping to keep the balance and supporting the proximal part of the transverse arch. So this is what you can see here. Pronation made by the fibularis longus and supination is made by the tibialis anterior muscles. So they are forming this tendon loop. Okay, body weight distribution and support. So there are three bony points where your body weight is supported: the head of the fifth and the first metatarsal and the calcaneal tuberosity. And since the lateral longitudinal arch is much lower than the medial one, so here you also have this line on the ground basically. Okay, so that's the normal footprint. And obviously there are lots of things which destroy these arches. Mainly the distal transverse arch can be destroyed by high heels and other factors as well. So too much standing, so those types of jobs can also contribute to disorders there. But these different disorders are not that easy to fix actually if they're developed. All right, so that was it for today. Thank you very much for your kind attention.